Welcome, everyone. I'm Sarah Emond. I am the president and CEO of ICER, and I'm thrilled to be with all of you today. We have a fantastic panel assembled to talk about our very first launch price and access report. I'm joined today also by Felucia Agboola, our Senior Vice President for Research, who's going to take us through some of the key findings of our report. And then we're going to hear from three fantastic panelists with their views of how we did with this very first attempt to look at launch prices and access, especially with an emphasis on net pricing and what's going on there. So let me just introduce our three panelists before I turn things over to Dr. Agboola. Antonio Chacha is with us. Antonio is the president of 3 Access Advisors and the CEO of 46 Brooklyn. Antonio spends a lot of time thinking about drug pricing, specifically through the 46 Brooklyn research work that's looking to improve the transparency and accessibility of drug pricing data for the American public. Antonio, thanks for being here.
Great to be with you.
Also joined by Cora Opsahl. She's the fund director at 32 BJ Health Fund. If you don't know 32 BJ Health Fund, you should be paying attention. The work that Cora is doing, directing a very large labor union plan, 200,000 members, with an emphasis on affordability and access, is something to behold. Cora, I really appreciate you bringing your perspective today.
My pleasure. Thank you.
And also Brian Reed. Brian Reed is the editor of Cost Curves. If you have not signed up for Cost Curve, please do. It is an excellent summary of everything that's happening in the drug pricing world, conversations about value, and even some hilarious memes and GIFs at times. Brian has a long career in journalism, public policy, public affairs. He also runs Reed Strategic, and is a senior fellow at the Center for the Evaluation of Value and Risk and Health at Tufts Medical Center. Brian, appreciate you being here.
Well, it's going to be a great time. Can't look forward to the discussion.
Thanks so much, Brian. And with that, it's my pleasure to introduce our Senior Vice President of Research, Dr. Felucia Agboola, who's going to take us through some of the key findings of our first report. Felucia, over to you.
Thank you. Good afternoon, everyone. I'm going to be providing a high-level summary of our findings in this very first report. Broadly, we focused on 3 analyses in this report. First, we evaluated the year-to-year trend in launch prices. Secondly, we also, for a set of drugs that ICER previously reviewed, evaluated the health system impact of prices above ICER's health benefit price benchmark. The health benefit price benchmark is a price range that aligns fairly with the overall health benefit the treatment provides for patients based on the data available at the time of launch. And then thirdly, we evaluated patient access barriers to newly launched drugs. At the beginning of this project, we organized a multi-stakeholder working group to help provide input into the approach and the methods for this report. And we had a chance to work with them at various points during this report. They had the opportunity to give us advice and input into our research protocol, which we posted earlier this year. Before our final report, they also had a chance to help review a draft version, and they provided their input and comments to this. Throughout the course of this project, we also had the opportunity to work with various stakeholders for the drugs in scope that had been previously reviewed by ICER, including certain patient groups and manufacturers. Now, turning to the year-to-year trend in launch prices, we evaluated novel drugs that have been approved by the FDA over 3 years between 2022 to 2024, excluding certain products that have different pricing strategies, such as vaccines. In total, we included 154 drugs. And for these drugs, we evaluated the trends in both list and net prices. As I'm sure many of you are aware, net prices themselves are not transparent. And so we had to come up with an algorithm that would help us to get to what we consider the best net price estimates. And broadly, for provider-administered drugs, we prioritized the ASP because this is reported by the manufacturer and it is what most manufacturers pay. Of course, we acknowledge certain limitations because this does not include certain discounts, such as the ones paid by the 340B covered entities. For non-provider administered drugs, we used gross to net discount rates from multiple sources, including IPD Analytics and SSRL. And in all cases, we prioritized manufacturer-provided estimates above all other sources. We shared what we consider the best net estimates with the manufacturers of the drugs that have been previously reviewed by ICER, giving them an opportunity to correct us. Only 2 manufacturers actually provided us with net estimates that we could use. As part of our analysis, we adjusted for inflation and various relevant drug characteristics, such as the drug type. This table provides the median annual list price and the median annual net price, the rightmost column showing the numbers after adjusting for inflation. And our analysis showed a change of 24% from 2022 to 2024 after adjusting for inflation. And we saw a larger increase on the annual net launch price of 51%. As we can see from these graphs, the change was more significant between 2022 and 2023. Given the differences in the mix of drugs approved each year, we fitted a multiple linear regression model to adjust for various drug characteristics that may impact launch prices so that we can examine the underlying trend in launch price independent of the types of drugs approved per year. Analysis showed that the annual launch list price increased by 25% per year, while the annual net launch price increased by 33% per year. As part of analysis, we found that certain drug characteristics were associated with significantly higher launch prices, such as gene or cell therapies, orphan products, and specific therapeutic areas, including oncology drugs. Turning to the set of drugs that have been previously reviewed by ICER, we estimated the potential savings in healthcare spending if priced within ICER's health benefit price benchmark. And we calculated the opportunity cost associated with excess spending on these drugs. In total, ICER had reviewed 24 of the 154 drugs in scope. And from these analyses, we excluded one drug, Paxlovid, because it was used before its FDA approval under a different pricing strategy. Analysis showed that 16 of the 23 ICER reviewed drugs in scope at annual net prices exceeded ICER's upper bound of health benefit price benchmark. This rightmost column shows the additional discount that will be needed on the net price to fall within ICER's health benefit price benchmark. For this set of drugs, we calculated what the excess first-year drug spending would look like by calculating the difference between the actual first-year drug spending and what the estimated drug spending would be at ICER's health benefit price benchmark. This yielded a first-year excess spending of about $1.3 to $1.5 billion. This graph shows distribution across years. As we can see, a significant proportion of the excess first-year drug spending is from the 2024 approvals. In order for us to contextualize the excess drug spend, we estimated opportunity costs in different ways. For lost EVOY, assuming each $100,000 spent is equivalent to an EVOY lost, we estimated between 12,600 and 15,000 EVOY lost. Basically saying that more than 12,000 fewer life years in full health that could have been achieved with optimal spending across the US population. Also assuming that the excess drug costs are fully passed on to all US enrollees as premium increases, we estimated between 97,000 and 115,000 individuals losing insurance coverage. And based on data linking insurance coverage to mortality, we estimated between 350 and 400 deaths. In our report, we varied some of this assumption and did various sensitivity analysis around this. Turning on to patient access, we focused on the 2024 launches. In total, there are 54 drugs. And as you can see in this table, unfortunately, due to data limitation, we didn't have data on all the drugs in scope. And also, due to data limitations, we were not able to evaluate coverage restrictions using the ICER Fair Access Drug Coverage criteria as we had hoped. Analysis showed on coverage policy availability, as you can see, only 2 had available coverage policies explicitly indicating non-coverage. But in general, it appeared that there is at least a 6-month delay in posting coverage policies. As we can see, for some of these drugs that have been approved, even for more than a year, there's still a significant proportion of health plans that had not posted the coverage policies as we were doing this evaluation. Interestingly, therapies with the highest rate of available coverage policies are cell or gene therapies. In terms of real-world prescription field data from pharmacy transactions in the first quarter of 2025 for those with commercial insurance, we found that on average, only 42% of commercial new-to-brown prescriptions were covered. Now, due to high rate of abandonment, maybe due to cost issues, on average, only about 29% were ultimately successfully filled. Rejection rates were greater than 50%, regardless of first-in-class status, orphan drug status, or whether ICER deemed this drug to be cost-effective or not. Non-coverage of the drug was the most common reason for rejection, which likely reflects coverage policy lag. Turning on to patient cost sharing, overall, there was a high percentage of $0 cost for many drugs, likely due to manufacturer assistance programs such as copay cards. There was also, this could also be due to patients with high deductible plans meeting the deductible or out-of-pocket max for the plan year. There are a few notable exceptions to this. For some of the drugs paying, for some of these, some patients paying over $250 in terms of patient cost sharing. We also got a chance to do a focus group discussion for a number of these drugs in scope that ICER previously reviewed, where we got to hear from the patient community. We heard some of the issues around challenges related to insurance, such as step therapy and prior authorization. But we also heard some other barriers to access beyond insurance, such as the complexity in the health system, health inequity, or some of the issues related to the treatment burden itself. In our report, we comprehensively described a number of limitations that we faced in doing this evaluation, but just to highlight a few that I touched on initially, the actual net pricing data, as I mentioned earlier, are not transparent, and some of the estimates that we used from the best available sources may still differ from the true net price. And our evaluation of patients' access was limited to commercial payers. In conclusion, our analysis found that the launch prices of drugs continue to rise at a rate that exceeds inflation, GDP growth, and overall healthcare costs. And we highlight value-based pricing as an important approach to determining fair pricing that rewards innovation without causing harmful effect on patients through higher health insurance premiums. Our report also highlights patients' access evaluation barriers that are related to insurance, some of which may be fixed with early evidence evaluation and some non-insurance issues. Before I pass it on back to Sarah to start the panel discussion again, I do want to really thank all the data partners, the patient groups that gave us additional information on this report. And special thanks to our working group, and also to highlight that no member of the working group is responsible for the final content of this report, nor should it be assumed that they support any part of it. This report should be viewed as attributable to the ICER team alone. Thank you.
Felicia, thank you so much. I really appreciate that overview. We encourage everyone to take a look at the full report for more details, but we did want to ground the conversation in a little of the findings that we've made with this first launch price and access report. Felicia, if you could take down the slides when you get a second. Thank you so much. Perfect. So we want to dive right in. We've got about 45 minutes for reflections, suggestions, grievances. All of that is on the table for today because we were very proud of trying to do this. The big thing we were trying to do is look at launch price trends from a net basis because all the data limitations aside, and we're going to have a chance to talk about those limitations throughout the conversation today, we did find that drug prices at launch are going up even on a net basis. And so I'd love to have each of you sort of react to that finding. Does it track with what you're seeing in the data? Are you surprised? Are you not surprised? And then we're going to go through a little bit more on what we found on the access piece. We want to talk about some of the policy solutions that might be in front of us. And we're going to end today talking about where we go next with this type of analysis. Antonio, let me start with you. Did the findings of this report surprise you?
In general, no, they did not surprise me in the least. In general, what we can see over time is that it should come as no surprise that in aggregate, prescription drug costs continue to go up, right? And everybody is feeling that. Now, there will be a lot of things that go into what causes what we could just in a bucket call prescription drug cost growth. Usually, when examining drug cost growth, the first thing people typically look at is year-over-year increases in manufacturer list prices. And to be true, yeah, it's happening every year. In fact, list prices for prescription drugs go up year over year. They're down significantly from where they were in 2018. We were at a point where we were seeing about 8, 9, 10% year over year growth in list prices. We're down to about 4 or 5% year over year since 2018. But as many of us know, the list prices are in essence a figment of our imagination. We're looking at over $300 billion of value that roll off the top of those list prices. And so certainly utilization trends matter, certainly net costs matter, list prices matter, all of those things. But what is often boiling underneath the data research surface is what's happening with launch prices for medicines, right? And if for any analysis that examines launch prices, there are two things that you should expect to be true. One is that the list prices for launch drugs will be going up significantly over time at a rate that will eclipse what we see in the year-over-year growth patterns. The second thing is that underneath those list prices, you should expect that the net prices are going up as well. Whether we like it or not, the market is built upon churn, and you have manufacturers who are given patent exclusivity for a limited period of time, sometimes not limited enough, and it eventually gives away to competition, which lowers the underlying net cost of those products, either through genericization or biosimilars. Understand that when a drug comes to market, it is at peak value potential from a manufacturer's perspective, meaning that you should expect that there will be the tightest amount of gap between list price and net price at the time of a product's launch, and that will only grow over time, which is why oftentimes you will see in aggregate net prices may look as though they are going downwards, certainly much more than a look at just the launch price at the time of launch, right? You're going to see that to be the maximum value potential for a manufacturer, eventually giving way over time. But Sarah, in answer to your question, directionally speaking, there should be very little surprising about where we are seeing the trends on both a list and net price perspective at a product's launch.
Thank you, Antonio. Cora, next to you. Surprised by this finding? I know you spent a lot of time looking at healthcare costs overall, not just drugs, but sort of across the ecosystem. How did this track with what you see in your data?
I think any employer that pays a bill is not surprised by this. I think about it in the last 5 years, almost 6 years, we are spending almost twice as much before rebates on drugs than I was 5 years ago. Almost twice as much. My utilization has gone up. We can have lots of conversations about why I think that we're pushing utilization up in order to maximize profits. But the reality is most of that is just straight price. You can't account for the fact that I'm not doubling I didn't double my utilization in 5 years. My population is relatively stable. It's mostly price. Not to mention that the drugs that are coming on are the really expensive ones, right? We're not introducing new drugs to market that are in the hundreds of dollars. We're introducing them in the hundreds of thousands of dollars. And so, yeah, I think that any employer that pays a bill is not surprised by this at all. I think Antonio has a lot of the caveats and things like that, but from an employer perspective, there is no, it feels very difficult to be able to determine any other solution than it costs me more money every year.
Thank you, Cora. And I'm going to come back to you soon with what this means. So what are the implications of this for what you're trying to achieve by providing health insurance to your members? But Brian, you've heard Cora and Antonio say not surprised. Were you surprised, or was there something in there that made you go, I'm not sure I track with what we put out in the report?
I mean, I think everyone has an intuitive sense about what direction drug prices are going. And so to the extent to which that this may or may not have confirmed your priors, you feel better or worse. I think the question is, am I more convinced of the trends now than I was before the report came out? And that's a much more fraught question, Sarah. I mean, first, I want to emphasize something Antonio said, which is that for an individual product, over the course of that product's life cycle, the net price is probably going to decline. This is not an iron law. There's good data about what kind of products see those declines and which kind of products don't. But in general, if you're taking a medicine today, your insurance plan is going to get a better price on that drug next year and certainly 5 years from now or 10 years from now. And that's a slightly different question than at launch in aggregate, are net prices going up or down? And I think that's a really hard question to answer. And I know you're explicit, let's not talk about data limitations, but I want to make the point that to really understand whether or not net prices are going up or down, there's a lot of factors, especially in that first year or two a drug's on the market, that are going to impact patient access and patient affordability. On the one hand, as it was very well documented in the report, payers are going to throw up all sorts of barriers. And on the other side, you've got this, this counter effort by manufacturers through patient assistance and a lot of other, factors to make those drugs as accessible and affordable as possible. And that interplay doesn't always show up in again, there was a very hard work done to try to get to the bottom of this, but the system is so complicated that I'm not sure we've got the answers. So, again, implicitly, intuitively, people are going to have a sense that, yeah, drug prices are going up. Do I feel like we've got the smoking gun? Probably not.
So one of the things, just drilling down a little bit on what we found, and one of the things that we've seen in our own work is that we've seen higher and higher prices, but sometimes those higher prices have been justified. And so we did look at the trend versus drugs ICERs looked at and whether or not the prices were aligned with the value from our determination. But the other thing we've learned in our work is that some categories just have higher prices, whether it's cell and gene therapy or orphan, oncology. And so we wanted to adjust for that in our analysis. And again, this is preliminary. This is our first one. Very excited for feedback about how we can do better next year. But we found that even when you adjust for those characteristics, that the trend, at least, was that net prices were still going up. This might be sort of a quick round for reactions to that. Surprising, not surprising, appropriate, not appropriate. Cora, let's start with you.
I mean, I think there's always exceptions to the rule. Like Brian, I think, can point out a variety of exceptions about why, it's going up. And yes, maybe in the end, the data shows that your net drug price for a specific drug is going down. But I think in the end, I mean, I don't know. I think about it from a market basket perspective. My pharmacy bill and the share of my pharmacy dollars that are now happening in the medical benefit is going up year over year. And that to me, that's all that really matters. So yes, we can talk about the value and whether or not it should be worth $100,000 or not. A, I don't have access to that level of information. And B, my bill is still going up and it's leaving, it's forcing employers to have to come to terms with how do they then provide that access. So from my perspective, it's like caveats aside, it still costs more.
Yeah. Antonio, how about you?
Yeah, I would say I often compare the pipeline of pharmaceuticals to a bucket, right? And new launch products essentially represent pouring water into the bucket. And we are heavily reliant upon a hole at the bottom of the bucket, which represents biosimilar and generic competition, which can and do work to significantly reduce the net cost of products over time. The challenge is that sometimes we're pouring too much water in the bucket relative to the size of the hole. And sometimes that means that the manufacturers are taking greater liberties with their net costs of new products to market. But it can also mean that somebody downstream in the supply chain is tightening the hole at the bottom, letting less and less leak out, causing essentially an overflow. It will ultimately be a combination of factors. Are you having more and more expensive net cost products that are entering into your product portfolio as a payer? Or simultaneously, is the supply chain withholding the savings that the marketplace is supposed to be providing, whether it's through things like spread pricing, pharmacy markup, specialty pharmacy overcharging, and all of those things that contribute to the aggregate picture of what comprises an employer or government program's aggregate drug spend.
And you're hitting on something I hope we get to when we talk about sort of policy options. And so I think there's a frustrating lack of transparency that many of us would agree with. And even if you're on the purchaser side, and I'll prod you to dig on this one a little bit, Cora, in just a minute, just not even having the transparency that you'd like for what you're paying for can create these dynamics where there's just, I love the budget bucket analogy. We're just pouring more water into the bucket while the hole isn't getting any bigger. But Brian, let me just let you react to the idea that even when you adjust for drugs that are typically more expensive, we still saw net price trends going up. Surprising?
Again, the challenge here is we've got an extremely small number statistically of new drugs every year, about 50. And there's a huge heterogeneity in those drugs. So even if you say, well, geez, we're only going to look at orphan drugs. Well, there's one drug approved, Viopause, where the company said, look, you don't even have to take off your socks to count the number of patients we're going to treat in the United States. It's less than 10. That's an orphan drug in the same way some of the myeloma treatments that are looking at a patient population of 30,000 are orphan drugs. And comparing apples to apples becomes really hard. So you can be thoughtful about the regression analyses, but you're just fighting, you're swimming upstream when it comes to the statistics. So we went and looked. Every company has to file a new drug report with the state of California. That includes the population size. In 2022, the median population size was 7,000. In 2023, that drops to 2,100. So there's this massive shrinking of the patient population. And what we know is that drugs with smaller patient populations tend to have higher prices. So is that what's going on? Or is there actually a trend towards higher prices? The reality is I'm not throwing out that one stat because I think that's the key. I'm just pointing out that it's really hard, even when you try to be thoughtful about regression analyses, it's really thoughtful to say, we've controlled for all these factors. We understand what's going on. Again, with a small sample with huge variability, I think that's hard. At the same time, I would like Antonio's bucket to not be muddy in the middle. And I would love Cora to have the data she needs to know, am I getting value? Are the drugs coming in at the top of, do we get champagne at the top of the bucket and Boone's Farm at the bottom? These are important things for everyone in the system to know.
This may, in fact, be the first webinar I've ever attended where someone said the word Boone's Farm. And so A+ for that.
I'm just glad that everyone here is like, oh yeah, I'm down with the Boone's Farm analogy.
Really
That's fantastic.
This vision of like the employers who are just drunk in a field right now, because that's really all you can do when it comes to drug prices.
Really,
I
think we're gonna use this analogy to death. I can feel it. Yeah, thank you for that, Brian. Let's talk about the patient access analysis a little bit, and then we're gonna dive deep in a couple of other issues. When we set out to do this work, we were sunsetting a previous report that we did every year called Barriers to Fair Access, where we were looking at data publicly available mostly to try to get a sense of how coverage policies from insurers were meeting the ethical standards we'd like them to in terms of ensuring patient access. And we found some interesting things over the years. Some themes here. Hard to find the data. There are lots of tweaks to policies that we weren't privy to that happen when particular purchasers ask for specific policies to reflect what they want for their employee population, etc. But we tried again. And this time we really tried to match what we could find out there for patient access to some of the newly launched drugs. And so Felicia went through some of the highlights. One of the big takeaways for us was that new to market blocks seem to be a persistent thing that is hampering patient access when something is newly approved. We did find in our research and in our discussions, there are some payers that are working to have temporary policies up that just match the FDA label on day one, so that there's at least a mechanism to have patient access before we get to a fully fleshed out coverage policy. But our work with the IQVIA data and the report also showed we continue to see a lot of rejections, whether it's not covered or step therapy wasn't met, and a lot of cost sharing for patients. Okay, so these are consistent findings that we've had over the years, and we're continuing to find them. I sometimes talk about this as the arms race, with higher and higher prices are met with more and more access restrictions. And how about now we try to de-escalate that arms race? But I want to give each of you an opportunity to reflect on what we found in our access report. Again, surprising, not surprising, matches what you're seeing. This time, Brian, I'll start with you.
I don't think it's surprising. Anyone inside, the industry knows that the hardest trick to pull off is getting coverage on day one, that it is now standard practice for payers to put up as many barriers as they can, despite the fact that they have data on the medicines, they have value data. And so I think the biggest takeaway for me from the report was that you very well documented exactly what those challenges are and how divorced initial coverage policies are from any measure of value, whether it's, first-in-class breakthrough drugs, whether it's, ICER's own reports. Payers aren't making these decisions based on the sorts of things you would think they are or would want them to, which raises the question, what are they making these decisions on, if not just this knee-jerk reaction to have less utilization, period, regardless of the benefit, regardless of the value?
Thank you. Antonio.
It stands to reason that if net prices are essentially at their peak at a product's launch, that there are minimal incentives, relatively speaking, for payers to adopt coverage of those products. We know all too well, whether we like it or not, manufacturers price drugs for their customers, and their customers are not patients. Their customers are not employers necessarily. Their customers are PBMs and their group purchasing organizations. And so prices both at list and net are calibrated with those interests in mind. As it stands, the higher amount of net value, the greater amount of discounts can be most enticing to a PBM's favorable treatment on a patient or on an overall benefit plan formulary. So as a result, it's not surprising to see PBMs and payers essentially dragging their proverbial feet when a product is first out of the gate. Now, be clear, not all of that is going to be ill intent on the part of the plans and PBMs. We also suffer from a little bit of a chicken and egg phenomenon. Manufacturer patient assistance programs essentially set the table for allowing PBMs and plans to delay coverage. Essentially, it stands to reason, if I'm a manufacturer and I say, look, I have this very expensive product, I'm going to offer a great patient assistance program to ensure that upon the product's launch, I can get those patients on those products. So hopefully they will be on them in perpetuity. Well, PBMs and plans know that, right? And so as a result, are very quick to delay adoption of a drug on a formulary, knowing full well that the manufacturer will essentially pony up for the first administration of that product once it's on the market. So it shouldn't come as a surprise that those plans will delay or deny, anticipating the manufacturer will have enough patient assistance kind of fill in that coverage gap.
Before I invite Cora for her reflections on that access piece, I can't resist the opportunity to just speak, wow, what another area of added complexity that does not center the patient getting access. I mean, that's shenanigans, right? I mean, like that is really quite remarkable that we've been able to come up with such hilarious barriers and factors when we're like, oh, wait, it's okay. They're going to get a patient assistance program, which we can have a quick side note talking about how that's also a reflection of your ability to navigate the healthcare system, whether or not you can find that patient assistance program. So there's a fair amount of privilege just in that understanding. And then if we get them on the drug, then we don't need to worry about having a coverage policy for it right away. Okay. I'm going to try to remain optimistic and not get too depressed with some of this. But Cora, on the access piece, similar to what you guys see and how your plans are thinking about access at launch, they have new to market blocks. What was surprising or not about that?
I mean, of course I have new to market blocks and I will continue to. This report does not make me want to change that. And if I think about it, like, and the reality is because I have 200,000 lives. If, like Brian said, that the average drug now impacts 2,100 people, why would I put that on my pharmacy unless I happen to, like, on my formulary, unless I have that one person? And if I have that one person, there is exception pathways. There's exception pathways in the medical benefit. There's exception pathways in the pharmacy benefit. We can have an absolute discussion about whether or not those exception pathways absolutely work, but that's a slightly different conversation. I mean, that's a separate conversation. I think I will continue to do that, in part because, frankly, you get things like the Duexes of the world, where the drug that was coming on is costing me 3 times as much more than that than it would to send people over the counter to get their, Pepsid. So I think as a plan, and I would like to point out that you all are talking about the payers. The payers in this instance, they're the employers, right? The carriers and the PBMs are not paying for this. Yes, in Medicare and Medicaid, it's a different world. But for most patients out there, 2/3 are in employer-sponsored coverage. Most employer-sponsored coverage is self-funded. So when you start to look at that, especially if you're tiny, you got to put some guardrails into something that's going to bankrupt your plan. And the reality is, if I'm a little bit of you, we have to rely on the people that we're hiring to do this work. I will have plenty of soapboxes. I can talk about how I think plans should stop punishing their sickest patients and should not be putting co-insurance on specialty drugs, and that we should not be categorizing things differently that way. I will talk about it till I'm blue in the face, that I think deductibles and co-insurance is an unethical process, especially on the pharmacy side, because all you're doing is delaying care. But that is not, like, that is a very specific thing unrelated to the conversation at hand. But I will happily talk about that to anyone who will listen, because the reality is, though, I need to stop those new to market drugs, because whether or not it is accurate, my perception, and I am pretty with it in the marketplace, is I couldn't say that there's not some profiteering happening at the pharma level, finding new drugs to the market that are going to be more expensive, finding new ways to figure out how to do this, because, well, we had the generic cliff in the 2000s, and then all of a sudden there was really no drugs. They're fighting against biosimilars. I'm going to talk about the unethical nature of PBMs owning biosimilar manufacturers, but you've got that piece, right? Like, the industry is so set up, trying to come up with a word that doesn't use the word graft, but like is so set up with so many layers that as the ultimate payer, I have to at least put a little bit in place to control my costs. So I said a lot of things in there, and I just saw Brian continually giving me hearts, but like that's the problem, right? How do you actually talk about value and cost? And then we can talk about rebates and the lack of visibility into that. And if you have if it's a medical drug, you get 0 of them. Like, how are you supposed to expect us to do this? The easiest way right now is to do new to market blocks.
Well, you did cover a lot there, and there was a lot of nodding heads among, not at all. No. What I wanted to frame for my reflections on the access work that we did this year, which we are, again, trying to build on for next year. So advice is welcome, is that we are so thankful that we were able to work with the National Health Council, and we talked to some patient groups, and we said, well, talk to us about your access challenges. And there was only a segment of that had to do with insurance coverage and cost sharing. Yes, that came up, but they also can't get appointments with specialists, and they have trouble with transportation. And some of them face unbelievable stigma in the system about their condition. So like, if we want to handle all of that, like, we really do need to focus on what we have some control over, even though it feels out of our control, but we have control over how much we pay, how quickly we get coverage policies up, how we do clinical, evidence-based coverage policy development. Like, these are all choices we can make so that we have that problem go away while we deal with all of the other things that are hindering patient access. But Cora, I'm going to stay with you on this because you've touched on this. Sometimes, most of the time, you don't know net price. You don't have any visibility there, but that means there are real world implications for what you can do for your employees. So tell me a little bit about what that feels like in terms of these real world impacts, the choices that you have to make because this part of the spending pie has been going up.
I mean, I think the reality is you have to rely on your PBM and your brokers and your consultants. And you do, and Brian, it's an excellent face, but you do. I mean, if I don't, so like, let's think about, I'm going to use a real world example. I know what my net cost is for a GLP-1. I will not break any confidentiality by sharing that, but I now know what my net cost is for a GLP-1. It's not that expensive. It's not that expensive. You know, if we're, and we'll just use the cash price, which is roughly $500 a month. I'm not saying that's not cheap. Let me be 100% clear. I'm not saying that $500 a month is cheap, but it's not the $1,200 or the $1,300 that you hear about, right? And for a plan, $500, the issue has more in that instance to do with the utilization of those drugs and the fact that the reports you're getting are showing it at the $1,200 or $1,300 and not at the net $500 component, right? But if you know that you're really getting at $500, it becomes a different, I think it's a different conversation. You have a different conversation. If a new specialty drug comes to market that is offering, you know, like the other day I got asked to add a new MS drug to my formulary. And I said, well, I've got 4 other MS drugs. Why should I add this? Not a clinician. And they're like, oh, but this treats a very different part of MS. Okay. Is it that no one else treats this part of MS, or is this a better treatment? Like, I don't know. And frankly, neither do the PBMs. Neither do the PBMs. And if the PBM account team who is telling you to add this drug doesn't know that it's probably because they're getting a higher rebate than the 2 MS drugs that do sort of touch this, or you might have to do a 2-drug cocktail, or all of those things that, again, non-clinician can think through. We are just, our hands are tied to people who have the in-depth knowledge. And on top of that, when you look at all of the things I have to care about,
Right.
Pharmacy benefits are roughly 25% of your spend.
Right. 25%
of your spend. So I would tell any plan sponsor to spend most of their time on the other 75%. PBM pharmacy matters, and if you look at the cost inflations, it's not, hospital prices are going up so much higher, and that's what you should be focusing your time and attention on. And I think that that's, you know, I think that sometimes we end up, it's a smokescreen, like, let's talk about this, but if you fix this much, you're not actually changing your cost curve.
Next time you talk to your PBM and they have questions, they can't answer whether or not it's good, please check and see if there's an ICER report that you could refer them to where we try to answer those questions about how much better it is and how much we should pay for it. But Antonio, 46 Brooklyn has been looking at this issue for a while. And you touched on this a little bit in your intro, but I just want to give you another opportunity. So like, how does this compare or not compare? Where did you see any like differences in your findings versus ours?
I think it's important to remember that drug prices are a lie, right? And basically start there, right? You have the list prices of medicines, which are essentially aspirational prices charged by manufacturers as essentially a ceiling of what they'll be able to yield. Pharmacies do the same with their own sticker prices. And in essence, I want to go back to something Cora said, you know, for better or worse, we need PBMs and we need those consultants to essentially help us navigate a world of lies. The problem is that the drug prices shouldn't be a lie, right? We have a system of necessity. Manufacturers are not adequately incentivized to compete by lowering their list prices. They compete by increasing their discounts. Pharmacies also have very little incentives to compete on the list prices of drugs. Thus, we have a system that requires PBM intervention. But unfortunately, PBMs are not pure in their incentives. They too are publicly traded companies who want to make money off the same things that manufacturers, wholesalers, and pharmacies do. So now you have to hire consultants like me, and we love that, right? You get to hire more and more consultants to oversee a system that cannot be trusted. So the ICER analysis is much like some things that we do over at 46 Brooklyn Research, right? Yes, I do consulting in my professional life, but you shouldn't have to hire me for most of the things that people hire us for. Because if drug pricing was simple, straightforward, transparent, and the prices were actually the prices, then you would not need nearly the amount of intermediaries to watch the intermediaries and consultants to oversee those intermediaries, et cetera, et cetera, et cetera. The consultants continue to love this system because it requires a distrust but verify approach. So yes, everything that we see in this ICER report directionally checks out with the things that we see. But it is important to remember, just as is disclosed in the report itself, we live in a system of lies. So we must rely upon what is publicly available in order to come up with directional understandings of how that marketplace works. We shouldn't have to guess, right? Much, and I'm sure, Sarah, you would say this exact same thing, is that if manufacturers and PBMs and government programs would just be honest and transparent about the real prices of these drugs, we wouldn't have to rely on imperfect directional analyses to try to surround a problem. We would know exactly what it is.
I think that's right. And I think that's one of the reasons we were really excited to take this on, because, and we'll talk about policy solutions in just a moment, we think that there are opportunities for us to de-escalate this. And, you know, as I mentioned before, I mean, I think the other thing that is important to note about why this is hard is that a lot of people are making a lot of money off of the status quo. And so when you have a system with a lot of people benefiting from high list price, big rebates, and the formulary games, change is hard. It doesn't mean we shouldn't try, which is a little bit of how we keep motivated at ICER, is that we will keep putting out information that will hopefully get towards more transparency. But transparency alone, I don't think, is it. And Brian, I'm going to throw this one to you, because so then we know what the price is, but then how do we know if it's fair? And you talk a lot in your consulting work and your newsletter about communicating about value. And we did ask people, the manufacturers in scope, to tell us how they came up with their price. We got some interesting answers. Some were talking about their own value analysis, but you've been beating this drum for a while. Why do you think it's so important for companies to talk about this value question?
Well, a week ago, I would have said, well, you know, fundamentally, it's important because, you know, everyone in the supply chain needs to understand what the manufacturer's perception of value is so that they can fashion their coverage choices appropriately. And then we find out that that actually has zero impact whatsoever, that there's no consideration of value, and that poor Cora doesn't, you know when a new drug comes to market, whether or not it represents value or not. So, you know, unfortunately, the big one is they should talk more about value and price, because that's an important input into the system. It turns out from the report that that's not the case. Now, I think there are other reasons to talk about it. You know, number one, transparency is, you know, Sarah, you said it's not enough, but it is an intrinsic good. It helps us better understand what's going on. I am not rooting for Antonio to be out of work, but certainly the better data we have, the more transparent data we have, the less we would have to rely on these analysis of giant data sets to extract some sort of truth. And second, talking about price, talking about value is a good way of illustrating some of the fundamental parts of the healthcare system and this incredible complexity that people don't understand. If the pharmaceutical industry hadn't begun transparency reports and talking about the nexus between list and net price, I'm not sure we would be having this conversation at all. But the fact is, there's 10 years of really smart conversation about transparency that has opened the aperture on gross to net spreads and things like that. And that's good and useful. And you can come up with, dozens of other examples. I think we're having a much smarter conversation about gene therapy right now because the manufacturers involved in gene therapy have said, yeah, $3 million, but it's a good deal, and let me explain why. And so we've had a good, smart, value-based discussion around gene therapy that maybe we haven't had in other parts of the healthcare system. And I would like to see more of that from a reputational, from an educational standpoint, even if at the end of the day, maybe it's not impacting actual access and reimbursement the way everyone would like it to.
Brian, I feel compelled. I can't let it go. If you don't want to believe our data because the N was small, so please also don't believe it that it's universal, that payers aren't worried about and thinking about paying for value. I know that there was a finding in our access analysis that the sort of new market blocks and some of the access restrictions did not correlate with whether or not we found that the drug was fairly priced, but we know from a lot of conversations with payers, PBMs, and purchasers, there are payers and PBMs and purchasers out there that are insisting on a value-based price and rewarding that with access. The end might be small, but we're working on it.
Hey, the more the merrier when it comes to data. Like, you know, they say anecdote is not the plural of data, data is not the plural of anecdote, but, you know, honestly, the more stories we can have about manufacturers and payers thinking hard about this stuff, the happier I'm going to be.
Well, one of the things we highlighted in the report, and I love to take every opportunity to mention it, when Eisai launched lecanemab for Alzheimer's, they issued a press release with their cost effectiveness analysis and how they'd made certain assumptions to come up with a particular price. It was a little bit different than some of the assumptions that we made, and they came up with a slightly different answer. But I'd much rather have a conversation about that than I picked the price because I can, which I think happens quite a bit with a lot of the communications or lack of communications around price. Let's spend the last 10 minutes on where we go from here. And so, you know, we've talked about transparency. We have made some important strides on that. There's more information out there, like you said, about the gross to net spend, about some of the trends. But what do we do now? And so if we're worried there's still a lack of transparency, if Cora can't know the net price she's paying except for a small subset of drugs, how are we going to shift to a system that rewards value and with patient access? So Antonio, let me start with you. What are your policy goals here? What's your magic wand swinging around to do from a policy perspective?
I think ideally groups like ICER should live to inform the decision-making processes of PBMs and health plans and their plan sponsors, and essentially help guide that decision-making process. The challenge is that oftentimes people look to groups like ICER to replace the decision-making processes of those vendors because they are conflicted in that decision-making process. So unfortunately, in the real world, we look at value as the intersection of the efficacy of a product relative to its price or like competitors to that product. We rely upon a dysfunctional and conflicted system to make those decisions for us. The higher that list prices go, or the more disconnected they are from reality, the more we have to rely on those conflicted intermediaries to essentially sort it out for us and give us a more efficient system than the otherwise inflated list prices can create. ICER's worldview is more essentially about, hey, what is the price of this drug or the actual net cost in this instance relative to its actual quality relative to other products that are on the marketplace? But that is one view, that is one perspective of value. Understand that the drug companies have a different perspective on what value is. Most people will not agree with them, right? Other than drug companies. Insurance companies will have different perspectives on value. Patients will have different perspectives on value. But one important thing that we're not talking about is government's perspective of value of medicines. Understand that there's a lot of finger pointing we could put around the drug supply chain, but government is the first and most important distortion in our pricing of medicines in the United States. Manufacturers do not price their medicines solely based upon their value, not just to their own portfolio, but to the patients as well. They price their medicines based upon the expectations of those who cover and buy those medicines. Medicaid programs demand massive discounts from the list prices of medicines. The 340B program, which is intended to provide services to otherwise uncompensated care, that is another priority. Medicare now has their own inflation rebates, their own discount programs, right? The Department of Veterans Affairs, I could go on and on. But we look to the high list prices of medicines to do far more than just essentially provide a, quote, value for the underlying product. We demand high list prices to provide massive discounts and savings that can be used to fund things that are not drug affordability for patients and not drug affordability for people like Cora's members. So I would argue that when you look at a drug's price, both its list price and net price, it's very important to remember all the things that we demand of value of those list prices. And to me, I want drug prices to exist for their own sake, not to subsidize the premiums or the hospital services or the Medicaid programs or the general revenue funds that have nothing to do with the actual value of that drug.
Thank you, Antonio. Brian, wave your magic wand. What are the policy options?
I'm sorry, Antonio. Antonio dropped the wand there, so I'm not sure I have a whole lot. But I think to build on that, we need to change the incentives to put more value on this, again, away from the playing games and more, to really, again, incentivize companies on all sides to do the right thing. And right now, I don't think that those are in. And Antonio brought up government programs. Sarah, you talked about the anti-amyloid therapies in Alzheimer's. So again, a lot of time and energy has gone into making that case. And yet, if you look at the Medicare program, leaving aside GLP-1s, which are, obviously by statute, you can't cover those for weight loss. Alzheimer's drugs are the most restrictively covered in Medicare. There is a national coverage, and there's coverage with evidence determination, and there's all kinds of extra paperwork, and there's a debate about whether or not that's onerous or not. But the fact is, we have this whole structure built around the fact that we're worried about value of Alzheimer's drugs, and yet the companies that are out there trying to make that case haven't made the headway. So again, what's the incentive to do the right thing and to talk in the right way about these programs if, in fact, whether it's for the reasons outlined by Antonio or what CORE is facing, there's really no reward for doing that. I would love to see that change. I mean, I think the second thing is, let's not also move in the direction of policy solutions that move us even further away from that. But that is way more than we've got time for.
We'll have another webinar where we can go deeper on that and talk about what happens when there's FDA approval for a drug with very limited evidence and what do payers do, which can explain a little bit of what was happening in Medicare in that space, with the important asterisks that it's probably time to update the thinking on that because we're a few years away from it. Cora, wave your magic wand.
I mean, I think transparency shouldn't be something you have to actively fight for in contract negotiations, right? I'm getting my claim line level rebates next year. And part of the contract negotiations is that I get to tell everyone I'm doing that. Because if I can do it, which means other people, nobody can tell it, well, my PBM doesn't do that. Well, yeah, they do. And all big three of them said they would. So let's just be clear. Don't let them tell you otherwise. But I think that Antonio's point was really valid, is that the problem with high list prices is it's subsidizing the low prices, right? This is the problem with commercial in general. Commercial coverage in general is subsidizing the low priced healthcare. And so I don't know how to solve that, but except to start with, I think transparency is not the silver bullet, but you can't fix what you can't see. And so to me, we need to move to a competitive environment. And the reality is drug companies would compete on value if there wasn't this obfuscation of price. So I would say, let's start with transparency. And then I think we can go from there, because until we know what we're looking at, I don't know if we know the right solution.
It's hard for me to think of 3 people I wouldn't want the advice from for this next question more than the 3 of you. So about 30 seconds each. What do we do different in next year's report? What do you want to see us change or add or adjust? Brian.
I think there needs to be more directness about the data limitations and how that might impact the overall conclusions. I don't know that statistically looking at that small sample with that variability allows you to say things like was in the headline of your press release. Doesn't mean that the sentiment is wrong. There's just a lot of statistical certainty that's not there. And then I think as has been raised, there are a lot of factors that go into those prices over the first couple of years. There is patient assistance programs. There's the impact of Medicaid discounts at 23% straight off the hop. That flows into the 340B program. A lot of that wasn't accounted for. None of this makes your job easier. None of this is going to make the overall conclusions more clear or easier to calculate. But that's what we need to do, I think, to get the best holistic picture of what's going on.
Thank you, Brian. Antonio.
The first thing I would advise is just remember this report as a milestone, right? The first report, right? Anytime we do a report, I go back and I'm like, man, I would have done like 5 different things, than we did before, right? And I know you're gonna have those feelings too. But I would also just take that sentiment. I would look and say, what happened to the net value of those drugs maybe the next year, right? Are you able to see the ones that you looked at this time, so you could start actually trying to create some sort of predictable model to say, here's how much value we know will be lost over time on these products that first come in expensive, right? Those, again, the marketplace is designed to have new products be the most expensive, right? And then they have to give away value over time through competitive dynamics. I think that's just as important as looking at something at the front end. So, and look, if back to my magic wand, if I could hold it, require those drug companies and PBMs to be honest about the net prices rather than having to go to SSR Health and having to guess what they are.
Thank you, Antonio. Cora, what do you want to see different next year?
I actually really liked Antonio's idea. Because I think part of it is because it's hard for the layperson to understand value, and it's even harder for plan sponsors who've got a million things going on, understanding like, okay, if this drug came to market, the price was really high, but now we're down here. Perhaps we can get to a place of like, how does the manufacturer assistance programs change? I think it's starting to do it where it's more like you start to see a cohort, and how does next year compare to this year, and how does then and so on and so forth, because the more you talk about it, the more we will have these conversations, and the more I think we can start to talk. I remember back when I worked at a PBM, and when ICER first came to it, and there was a whole discussion about whether or not PBMs should leverage ICER. And so I think the reality is these conversations, because of transparency and these types of things, we're moving forward. Continuing that through line and not just starting fresh is the right answer.
And deeply grateful for the three of you for spending time with me and with all of us today to have this conversation. As we wrap up, I'll just mention that the thing that's motivating me and ICER to keep doing this is when we quantified what we're not able to pay for when we overspend on drugs that are priced out of line with value, we are actually harming patients. And we need to keep that in mind as we think about the policy solutions in front of us that center more affordable access for patients. You can quibble with the math, you can quibble with the approach, but directionally, if we're continuing to pay for drugs out of line with the value that they are demonstrating for patients, we're doing real harm, and we can make different choices. So thank you all again for being here. I look forward to next year's report, and maybe we'll have this conversation again. And for the audience, please let us know what you thought of our first launch price and access report. We're really excited to hear your feedback. Thanks everyone for joining today.
Thanks, Sarah.